Okay, welcome everyone to the current advances and future directions of peripheral nerve stimulation. Before I hand it over to ASIPP Chairman of the Board and CEO, I'm going to go through a few housekeeping items. Regarding your audio, if you are listening with your computer speakers, make sure your speakers are on and the volume is turned up to an audible level. If you experience audio issues, you may dial into the conference using the dial-in number listed in the webinar registration link. To ask a question, click on the Q&A tab at the bottom of your screen, type your question in the box, and hit the submit button. We will attempt to answer as many questions as we can today, and you're welcome to submit them at any time. We will answer these questions at the end of the webinar during the panel discussion. Your handouts, you should have received an email from ASIPP with the link to the handouts that go along with today's presentation. If you cannot locate that email, use the Q&A tab to request the email be resent to you, and we will add those at the end of this webinar. Any technical issues throughout tonight's webinar that you might experience, try refreshing your browser stream. If this does not help, you may exit out of your browser and log back into the webinar the same way you did the first time. And I'm handing it over to our Chairman of the Board and CEO, Dr. Laxmaiah Manchikanti.
Thank you, Karen. Okay, so I will finish pretty fast. And I just want to talk about that peripheral nerve stimulation is medically necessary. It is not investigational. So we are going to have an expert webinar on this evidence, indications, and techniques of PNS in chronic pain. This is a precursor for our cadaver workshop. So we would like all of you to join the cadaver workshop. So here is my disclaimer. There are no credit hours for this, so I don't have to worry about any, and I don't have any conflicts. So again, thank you for joining us. So by end of this session, you should understand why PNS is medically necessary, what actually the evidence says, trials, systematic reviews, guidelines, and where it fits clinically. So interventional pain physician, we have a neurosurgeon also here apart from anesthesiologist. So it is not really experimental, so we should be treating patients properly. So we have History and Future of PNS by Dr. Slavin and Evidence-Based Guidelines by Dr. Sanapati. Technical Aspects of PNS, Head and Neck, Brian Bruel, Upper Extremity, Alan Dennis, Low Back and Lower Extremity, Andrea Trescot. Then we will have a panel discussion and you can ask questions there. So what is peripheral nerve stimulation? We all know this, and it is the stimulation of electrical impulses, and peripheral means outside the brain and spinal cord. So target is the peripheral nerves. Approach is minimally invasive, percutaneous. So our pathway is a temporary trial leading to permanent implant. Category is neuromodulation. It is non-opioid and reversible. So is it investigational or medically necessary? The outdated label is that either experimental or investigational still in multiple coverage policies. It leads to claim denials and prior authorization barriers. It blocks access to a guideline recommended therapy. It is also recommended by LCD. The reality, we have 50 years of clinical experience. We have multiple FDA cleared class of devices and backed by RCTs, reviews, and formal guidelines. So there is a good track record measured in decades, deep roots ever since 1960, soon after the gate control theory was published in 60s, not 60, but 60s. It is a proven concept, and it has been established in different countries, different centers, different specialties. It is a modern leap. Early systems needed open neurosurgical implantations. Today, percutaneous devices made PNS far less invasive. So if you look at the approval status, in 2015, StimRouter was approved. 2016, Sprint PNS. This is somewhat different. It is a temporary stimulation, about 60 days or so, and then you take it out. And their theory is that it is going to help you on a long-term basis. And then we have Freedom PNS, Curonics from 2017. And in 2019, we have Nalu Medical, Reactive 8 from Mainstay Medical. This is for low back pain. So built on real evidence. So we did the systematic review and published in 2024. At that time, there were 7 systematic reviews, 8 randomized controlled trials, 9 observational studies, high quality, or quality which met the criteria to be included. Now, there are 2 more systematic reviews, and then I think there are 3 more randomized controlled trials. There are multiple observational studies. So utilizing GRADE and AHRQ methodology, we used rigorous standards and developed the evidence. So this is about 92 pages, 374 references, 20 tables, 9 figures. So evidence recommends that it supports implantable PNS for moderate to severe chronic pain for patients refractory to 2 or more conservative treatments following a successful temporary stimulation trial. Our aim is better outcomes and improved access to care. So we came up with fair evidence, level 3. We didn't want to be very much biased and industry focused. So implantable PNS after temporary trial, moderate certainty. It is useful in orocranial nation, craniofacial pain, phantom limb pain, low back pain. Again, this is moderate to severe chronic pain. A clear diagnosis and identifiable nerve target, refractory to or more conservative therapies, not primarily better served by other treatments. A temporary trial to permanent implant. And it is a non-opioid. So we know all the issues related to opioids. It is minimally invasive, reversible, mostly minor events. Why not investigational? Why not investigational matters? Because it improves the access, reduces opioid usage, better outcomes. So PNS is medically necessary care and our patients deserve access to it. It can be done at various levels, but most commonly it can be useful in knee and shoulder pain. Now occipital craniofacial pain with randomized control trial is available, intercostal and ilioinguinal nerve pain. Again, these are the coverage recommendations through LCD and also through our guidelines. 3 months, at least 3 months of chronic pain, documented failure of less invasive treatments and medications, no surgical contraindications, patient education and informed risk benefit discussion, no substance abuse issues, formal psychological screening, and trial with greater than 50% reduction in pain before a permanent implant. Some of the things are not covered by evidence: fibromyalgia, phantom limb pain, diffuse polyneuropathy, nociceptive pain, angina pectoris, peripheral nerve stimulation. So we are working on phantom limb pain to be covered. We have recommended that and also showed in the guidelines that that should be covered. Utilization limits, 2 of them per year. So these are the 5 points. It is 5-year history. It is FDA approved. It is backed by RCT systematic reviews, grade-based ASIPP guidelines, recommended for refractory moderate to severe chronic pain, level 3 moderate certainty. Therefore, PNS is medically necessary, not investigational. So now let us get started. Thank you. This is my address and enjoy the session. Next speaker is Konstantin Slavin, talking about history and future of the PNS. He is professor of neurosurgery and head of the stereotactic and functional neurosurgery section at University of Illinois, medical advisory board of the Facial Pain Association, authored and co-authored more than 100 chapters and peer-reviewed articles. He edited 3 books on peripheral nerve stimulation. He is the most published author on peripheral nerve stimulation, and he's the one who spoke at ASIPP meeting for last several years on peripheral nerve stimulation. He's associate editor of neuromodulation, neurosurgery, surgical neurology. He's board certified in American Board of Neurosurgery. Thank you, Dr. Slavin.
It's a great honor to be here, especially to follow you, who I greatly respect. It's a great honor for me to be part of the ASIPP activities, and I think it's particularly honorable since I already got the award for lifetime achievement. So I think I'm done with everything else, and I can rest now. But I can't rest until the peripheral nerve stimulation is fully approved. So thank you very much for doing this. And I look forward to speaking over the next few minutes about the history and future of peripheral nerve stimulation. The introduction that you gave is very comprehensive. You mentioned many things that I wanted to say, and I'll just reinforce some of them over the next 10 minutes. So you are absolutely right. I mean, my main bias in this particular way has to do with peripheral nerve stimulation being a subject of my scientific and clinical interest. It's a relatively small part of the practice, but I've been writing about this for many years. And since I work with every single company in the world that involved in peripheral nerve stimulation, I feel that I'm equally conflicted towards the entire field. I'm encouraging people who are actively involved in ASIPP to look at your sister societies, because I think it's important for us to keep working together in moving the neuromodulation forward. The interesting thing that the most fascinating updates in the world of peripheral nerve stimulation have nothing to do with science. They have to do with change in ownership. And as you probably heard, the 2 most recent news have to do with acquisition of 2 peripheral nerve stimulation companies, one by Boston Scientific, who acquired Nalu, and another one by Medtronic, who is buying SPR Therapeutic. And those are big developments, because the important thing about those things is that they underscore the relevance, importance, and timeliness of peripheral nerve stimulation, because it is now being treated seriously when large guys who rule neuromodulation for decades now are interested in peripheral nerve stimulation. That means that the field reached its maturity. But let's talk about the past for a few minutes, and then we'll talk about future, because the neuromodulation, as we know today, has mostly to do with spinal cord stimulation. Spinal cord stimulation was born in 1967 with the first implant performed by Dr. Shealy, who was a neurosurgeon who just recently moved to Wisconsin. Interestingly enough, the paper that came out a few months before Dr. Shealy's pioneering experience was written by those very doctors who postulated the gate control theory of pain, which was the basis for spinal cord stimulation. And illustrating the gate control theory of pain, Dr. Wall and Dr. Sweet, and Wall was of Melzek and Wall, those 2 people who actually postulated the theory, they wrote an illustration to gate control theory not through spinal cord stimulation. They wrote about peripheral nerve stimulation, because they felt that peripheral nerve stimulation illustrates how the entire concept works. And to show it in a series of patients and to show that it's safe and effective, they actually tested on themselves, on their own infraorbital nerves, showing that as long as they can create non-painful sensation through electrical stimulation, they can control perception of pain. So it was very interesting, because we feel like spinal cord stimulation dominates the world of neuromodulation, but peripheral nerve stimulation was there first. Interestingly enough, in the very same year, the paper was published talking about the use of peripheral nerve stimulation even earlier than that. So in 1962, before the gate control theory of pain was postulated in 1965, there was already clinical experience of using peripheral nerve stimulation for treatment of pain. This was a neurosurgeon from California, Dr. Sheldon, who published his experience with craniofacial stimulation, implanting peripheral nerve stimulator in patients with neuropathic facial pain. So that's in 3 patients, 2 did not have to have stimulation. Just implantation of device was sufficient to control their pain. But 1 patient used it, and it was high-frequency stimulation at 14,000 hertz that essentially provided a nerve block and controlled the pain that way. Now, since that time, many things changed. And the peripheral nerve stimulation we know today has evolved tremendously. In the world of pain specialists, we are familiar with peripheral nerve stimulation that is primarily used to treat neuropathic pain. Interestingly enough, if we focus specifically on occipital nerve stimulation, that thing was advocated and showed to be effective for occipital neuralgia, for migraines, for cluster headaches, and there is experience on use of occipital nerve stimulation for fibromyalgia. In addition to that, stimulation of sphenopalatine ganglion got approval in Europe for treatment of cluster headaches and was investigated for treatment of migraines. It never reached that stage in the United States because the company who was making equipment for this ended up out of business. So unfortunately, there's a hiatus now in evaluation of sphenopalatine ganglion stimulation. But this is just the tip of the iceberg. If you think about peripheral nerve stimulation, it is being used widely, not just by pain practitioners, but by many other specialists throughout the neuromodulation world. The phrenic nerve stimulation is used by cardiothoracic surgeons for diaphragmal palsy, for central sleep apnea. The vagus nerve stimulation is used by neurosurgeons for decades for treatment of epilepsy and depression. It just recently got approved for post-stroke rehabilitation with a paired stimulation during therapy. And even more fascinating, it got an approval for treatment of rheumatoid arthritis. So now there's a neuromodulation option with peripheral nerve stimulation to treat systemic disease. The sacral nerve stimulation, when we put interstim devices to treat incontinence or overactive bladder, be that Medtronic or Axonics, they are stimulating peripheral nerves. And similarly, when our colleagues from ENT world are stimulating hypoglossal nerve for obstructive sleep apnea, they are also using peripheral nerve stimulation. So these are approved indications for peripheral nerve stimulation that are being used today. And there's even more of them if you look through the world of peripheral nerve stimulation, because people are using it to stimulate carotid sinus nerves to treat hypertension and heart failure. The sphenopalatine ganglion was investigated to treat acute stroke with insertion of electrode in acute phase as soon as the stroke is diagnosed at the bedside into palatine foramen to stimulate sphenopalatine ganglion. The tibial nerve, pudendal nerve, saphenous nerve, they were all targeted for treatment of all kinds of gastrointestinal and genitourinary disorders. And the vagal nerve stimulation, the holy grail of peripheral nerve stimulation, has been used to treat heart failure, bleeding dysfunction, inflammatory bowel disease, Crohn's disease. There's a long list of possible indications for vagal nerve stimulation, including FDA-approved migraine treatment with non-invasive stimulation and so forth. But it's important to understand what we are talking about. And I tend to refer to Dr. Levy's paper that came out 15 years ago to differentiate different ways we stimulate the nerves. Because when we talk about TENS units, even though it has name of nerve stimulation in its title, it's really not stimulating the nerve. It stimulates nerve endings at best. The PENS, percutaneous electrical nerve stimulation, does stimulate the nerve, but without implant. That's when the electrode gets inserted, the stimulation gets delivered, and then the electrode gets removed. The true PNS we're talking about here today involves implantation of devices in the vicinity of a named nerve. And that what differentiates peripheral nerve stimulation for the last part of this, which is peripheral nerve field stimulation. Peripheral nerve field stimulation stimulates the area of pain without specific named nerve. And it's, to make it more confusing, people refer to it as peripheral subcutaneous nerve stimulation, subcutaneous targeted stimulation, or simply sub-Q stimulation. And that's different from classical peripheral nerve stimulation. Now, classical peripheral nerve stimulation, just like Dr. Manchikanti mentioned, was initially in the domain of neurosurgeons because we had to expose the nerve, we had to suture electrode to the nerves, and that's something that was not available widely. People could use it only in few dedicated centers by neurosurgeons, microsurgeons, plastic surgeons, and they would expose the nerve, put paddles next to it, sometimes suture them to the nerves themselves, or wrap the nerves with specially designed electrodes. And it didn't work well because it really was cumbersome, complicated, a lot of side effects and complications, and technically challenging. So things changed tremendously when percutaneous stimulation was introduced. And that happened just 25 years ago. The first paper on percutaneously inserted peripheral nerve stimulation came out in 1999. Dr. Weiner, a neurosurgeon, Dr. Reed, a pain specialist from Dallas, wrote this paper in a journal which was not well known back then called Neuromodulation. And they described something that revolutionized the field of the peripheral nerve stimulation, because suddenly the percutaneous stimulation became available not only to few surgical centers, but to pretty much everybody in the pain field. I participated in some of it in the very beginning when we started doing trigeminal branch stimulation, modified the occipital nerve stimulation. That was more than 20 years ago, and the rest is history. As a matter of fact, if you look at it now, the use of conventional devices, something that we use for spinal cord stimulation in the peripheral nerve stimulation world, is still there. So people use implanted electrodes connected to conventional generators, delivering peripheral nerve stimulation with either percutaneous electrodes or paddles. And you can see different examples here in both upper and lower extremities. However, things changed dramatically when dedicated peripheral nerve stimulation devices became available. And Dr. Manchikanti mentioned the timeline of approval for this, because this is something that is changing the world of PNS as we know it. So implanted generators are still being used for a variety of different PNS devices. The available in Europe system from NeuroImpulse uses very small generators that gets implanted in extremities. The device designated for post-amputation pain recently got FDA approved. It is something that is designed to treat pain in the amputation stump in lower extremities using high-frequency stimulation at 10,000 hertz. Multi-center studies showed that it was effective, and now it is FDA approved. I'm not aware of large marketing efforts behind it, but it's definitely out there. The FDA approved in 2020 device for multifidus stimulation is another example of peripheral nerve stimulation. It's being used widely, and we're probably going to hear more about this in a few years ahead. Finally, there's big multi-center study on the way with implanted generator that is stimulating both supraorbital and occipital nerves for treatment of migraines. That study is in progress, but enrollment has already been completed, and we're probably going to see some preliminary results very soon. Now, these devices have generators attached to them, but there's an entire cohort of devices, including the ones that are probably going to get more attention during this event, that do not require implanted generators. There are different ways to do that. The first one here on the left involves wired connection. When the electrode gets implanted in the patient's body, it's externally connected to generator and can stay in the body for up to 60 days. There's a direct current device, of which Dr. Manchikanti mentioned, called Stim Router, that was approved as one of the first. There's a radio frequency induction, like we see in NALU devices. And finally, there's wireless or microwave-based stimulation, which is provided by devices from SteamWave and now Curonics. These are just examples of that, what is on the market today. The long list of devices which are approved in the United States, from Bioventus, from SPR Therapeutics, from Curonics, from NALU, from Mod4 Stimulation, Mainstay, and Neuros. These are in the United States. Outside, overseas, we have approval for Medtronic and Boston Scientific devices. The St. Jude devices were approved at some point and then got disapproved. And ATI devices are not available because of bankruptcy. But Light Pulse from NeuroImpulse is used in Europe and outside in the rest of the world. There are many things in development: low-profile PNS, combined multi-target PNS, high-density interneural electrodes, electrothermal block, many things. And I'll just briefly mention them here, but we can have a separate webinar specifically talking about future things in that regard. But in general, what's important to know, the history of peripheral nerve stimulation is not just a set of events and anecdotal reports. There were actually very well put together studies about the use of peripheral nerve stimulation for established indications. Like, for example, this paper from 30 years ago showing improvement in patients with what we call now CRPS type 1, reflex sympathetic dystrophy, when pretty much every facet of patient's life improved over a long period of time. As a matter of fact, there is a paper showing that peripheral nerve stimulation remains effective for more than 20 years. And I dare you to find many examples of that outside of peripheral nerve stimulation literature. So this is something that patients were implanted in the 1980s, and then 20 years later, they were surveyed again and found that they are actually still using these original devices because they are so effective and so needed for the patient's pain control. So the evidence exists, and we're going to hear more about evidence which has been gathered recently. As a matter of fact, recent peripheral nerve stimulation evidence has resulted in many publications. The Curonics devices have been covered in multiple reports that come from different applications of this technology, be that in the extremities, be that in a craniofacial realm. There is now a lot of different meta-analysis and guidelines. And Dr. Manchikanti mentioned ASIPP guidelines, and you can see here that this is probably one of the largest and most best put together set of evidence that exists to support use of peripheral nerve stimulation for a variety of indications. And this work continues. There's more and more evidence get gathered. There are many reviews, which are in-depth reviews coming from different societies, different groups, focusing on peripheral nerve stimulation. And that makes this a little bit more legitimate. This is something that involves the field, kind of stimulates the people to do more, and kind of eliminates this concept of this being experimental and not proven. I will just briefly show what I think will happen in the future because I'm running out of time, but we can talk more about it later. There is now endovascular stimulation, which you probably heard about from brain-computer interface work by Synchron, but peripheral nerve stimulation can also be delivered through endovascular approach. There's a vessel next to each peripheral nerve, and if you can put stimulator into that vessel, you can stimulate the nerves. It has already been shown in both small and large animals, and it's probably going to get to humans very soon. You can also stimulate the peripheral nerve with very miniaturized devices. The Curonics device was a step in that direction, but there are many devices which are now even smaller, which are implanted into the human body to stimulate the heart, to change the patient's arrhythmias and so forth. The same thing will happen with peripheral nerves. We will see more of this with very out-of-box changes. Like, for example, the body generates heat, body generates energy through movement. And now there are devices which can gather that energy and energize the stimulation that we need. So this probably will be coming very soon to our arena. We will see devices which will dissolve over time. So you don't have to worry about explantational device. You can put something, stimulate the patient, and then leave it so it disappears by itself without need for explantation. There's many different examples of non-electrical stimulation. One of the best examples is magnetic stimulation, which is now getting approval for a variety of different indications. There are many publications focusing on magnetic therapy, and magnetic peripheral nerve stimulation is one of the best examples of how technology evolves. Interestingly enough, you can go outside of electricity completely, go to optical stimulation, and there is now optical peripheral nerve stimulation, which is used to stimulate vagus nerve. And that's something that has already been published. There's actually a very interesting concept showing that you can affect the conductivity of the nerve and velocity of the conduction through the nerve by adding the electrical and optical stimulation. And this is something that probably will revolutionize the way we deliver stimulation to our patients. You probably heard about ultrasound being used for treatment of a variety of disorders. The low-intensity focused ultrasound, high-intensity focused ultrasound, most of it is focusing on brain. But there is now applications that are using peripheral nerve stimulation or peripheral nerve application of focused ultrasound. And this is examples of low intensity, of more of the neuromodulation type approach. But there is also high-intensity focused ultrasound that can mimic ablative lesions in more tolerable fashion. So all of this kind of outside of electricity. Interestingly enough, there is now a concept of changing the conductivity with changing temperature. So this is something that is happening, and we see more and more of this in the PNS world. But what's the future of PNS? I would dare to say it's probably not going to be with us. Most likely, the peripheral nerve stimulation will become less and less invasive. And there are now devices which are approved for use of peripheral nerve stimulation using non-invasive interfaces. But it's a long way to go. And I think there is still quite secure future for all of us, neurosurgeons and interventional pain specialists, because there's plenty of things we can do. Thank you very much for your attention.
Thank you, Dr. Slavin. That was wonderful. So now we have Dr. Sanapati to talk about the guidelines. Mahendra.
Thank you, Dr. Manchikanti. Let me see my presentation. Okay, Karen, can you see my presentation, right?
It's just needs to be in presenter mode, and then you'll be
That's
good.
right. Okay, we're good.
It's,
Okay,
it's still not. Oh, there you go. It's good.
it's good? Okay. You can see it, right, Karen?
Yes, you're good.
Okay. Okay, thank you everybody for coming to this discussion today. And We had excellent speakers, Dr. Manchikanti and Dr. Slavin. That was a wonderful introduction about the therapy. And I'm going to mainly focus today on the ASIPP guidelines that were published in 2024 in Pain Physician Journal. These are the evidence-based guidelines for implantable peripheral nerve stimulation therapy in chronic pain. Dr. Manchikanti has given a brief introduction on this. So today we're going to look at mainly the results, recommendations, limitations, and the latest evidence. This is my disclaimer. Okay, what do these guidelines cover? So, as the previous speakers already said, the peripheral nerve stimulation has been in practice for about 50 years, and FDA has cleared these percutaneously implanted PNS leads from all these 5 systems. The objective of the guidelines was mainly showing the evidence-based recommendations for this therapy for moderate to severe chronic pain refractory to 2 or more conservative treatments. And these guidelines exclude the peripheral field stimulation and sacral nerve stimulation. So how the evidence was graded? There is a multidisciplinary panel of 31 experts, and only 23 people had voting eligibility because the other people had conflicts, so they couldn't do a voting on this. And the methods that were used for the evidence and recommendation strength is grade plus AHRQ. This is a modified ASIPP approach grade method, and AHRQ stands for Agency for Healthcare Research and Quality tools. And then the quality assessment was performed using a Cochrane IPM QRB. The QRB stands for Quality Appraisal for Reliability and also Risk of Bias Assessment for RCTs. And there's a Newcastle Ottawa IPM QRB NR. That NR stands for non-randomized studies. So that was mainly used for observational studies and also systematic review appraisals. This is how the quality was assessed. And the consensus was finally obtained using modified Delphi consensus. So the panelists without primary conflicts, that's 23 of them, got to vote. And each statement required at least 80% aggregate score to be adapted. So let's look at what these guidelines covered. We already looked at it. And then the evidence base at a glance. Dr. Manchikanti has already reviewed it. 7 systematic reviews in 2024. This was what we had. But now, in the last 2 years, there's a tremendous increase in the number of systematic reviews, RCTs, and observational studies. So finally, the recommendations developed were for 8. And all the 8 had a 100% consensus. So all of them were adapted, 8 of 8. So let's look at the evidence level and certainty. So basically, the 2 core effectiveness questions reached the rating of fair with moderate strength. So these effectiveness questions were implantable PNS following a trial. So that is the traditional way of doing it. Usually a week of trial. Some people do 3 to 4 days trial, and majority of trials are done over a week. Or selective lumbar medial band stimulation without a trial. That is the reactivate. The reactivate is the only PNS that is done without a trial. And the other methodology is using temporary PNS, that is sprint PNS, which is also called a PENS, percutaneous electrical nerve stimulation for 60 days. And usually people get much longer duration of pain relief after 60 days stimulation, and which is removed after 60 days. So this is how the traditional trial procedure is done, and also temporary PNS is done. So if you look at the effectiveness of these methodologies, you see fair to moderate certainty. So it's a moderate for both, and they achieved moderate certainty. So what defines a successful PNS trial? This is very important for the documentation when you do a trial to get it approved for implant. You have to document at least 50% reduction of target pain and also 50% reduction of analgesic medications. And you always have to document some improvement in function. You have to document something that they were not able to or difficult to perform before the trial, but they were easy to perform during the trial and after the trial. So that's very important. So these things need to be documented to get a approval for implantation in future. And also the screening is very important. The selection really matters because like if you accurate patient selection, if the selection is correct, then almost every trial goes to a permanent implant. But if the selection is bad, then most of them don't go to implant, and that may subject to an audit. So, for example, Noridian may do a post-payment review if the trial to implant conversion rate is below 50%. This was seen mostly in the office-based practices. They were doing a lot of trials, especially in the past, and most of the patients are not going to the implants. So this is not a good practice. So there are 8 consensus recommendations according to our guidelines. Every statement earned 100% acceptance to be a recommendation. So we looked at mainly the diagnosis, effectiveness, that's post-trial, and also 60-day PNS, and also expanded indications, and the importance of the device knowledge and patient education, and the risk stratification, effect of risk stratification, and if the patients are on anticoagulants, how do they affect? So the recommendations, if you look at the individual recommendations, the first one is regarding the value of diagnostic methods. So this has a moderate recommendation and the evidence level is low. So there is evidence supporting the accuracy and value of diagnostic methods for identifying conditions amenable to peripheral nerve stimulation. Especially some of the payers, if you look at spinal cord stimulation for like diabetic neuropathy pain or some neuropathy pain, they're asking for documentation of EMG, nerve condition studies, and things like that. And also, if they have seen a neurologist and they want to see that evaluation. So these diagnostic studies do play a role, and there's a low level of evidence and moderate strength. And effectiveness after a trial, we already looked at this trial of 7 days or 3 to 7 days, and then also medial branch stimulation without a trial. And there is evidence level is fair and moderate strength. And the 60-day PNS, that's the sprint therapy, and the grade level 3, fair, moderate certainty. And expanded indications, the indications based on all the literature we had in 2024. So we felt like the indications may be expanded beyond the current indications. That's craniofacial pain, phantom limb pain, and low back pain. And obviously, in the meanwhile, the craniofacial pain indication has received actually approval, and I think Chronics got the initial approval, and we started doing a lot of occipital trials since then. And the evidence level is fair and moderate for both of these. And the device knowledge and patient education. So understanding each device for the providers and also the patient education, there are very strong recommendations. The evidence level is moderate for this, and recommendation strength is very strong. So understanding each device, it's important to understand each type of PNS and its equipment features and technical requirements. That's how we can decide how to match the system to the target nerve and clinical need. So depending on the need and target nerves, we can choose the ideal system to justify for that problem. And the patient education is also very crucial. If the patients understand the procedure well, and if their expectations are realistic, and they understand how the device works, and how to maintain the device and charging and all this post-operative care, the outcomes are usually better. They don't have much surprises and worry about it. They have less anxiety. So coming to risk stratification and antiplatelet anticoagulation therapy, the risk stratification according to ASIPP, the implants of the extremity and other superficial nerves, these are considered low risk, and lumbar medial branch stimulation, the implants are considered moderate risk. And if these are implanted, either trial or implant in thoracic and cervical area, cervical spine, medial branches, trigeminal and cranial nerve targets, those are considered high risk. So the evidence level is moderate for this, and strength is also moderate. Coming to antithrombotics, antiplatelets, and anticoagulations, it's very crucial to know, based on the risk, low, high, or moderate risk, whether when to continue, when to discontinue, and when to restart the therapy based on the risk status. And ASIPP, we have developed an app. It's called ASIPP Antithrombotics. It's available on both iOS system and also Android platform. It's available for a very nominal cost, and you can download that, and it gives you very good recommendations on these aspects. You can plug in the procedure name and the anticoagulants or the antiplatelet agents the patients are on. and then it'll give you recommendations when you can start, you can hold, or you can continue, or when you can restart. So that's very useful. And key recommendation from these guidelines is expanding coverage beyond current CMS guidance. That's craniofacial pain, occipital, supraorbital, and related targets, and phantom limb pain, and also for low back pain. And since the guidelines in 2024, we had a lot of new RCTs and real-world evidence. So the high-quality trials published after these guidelines, they seem to strengthen the effectiveness for percutaneous PNS. So the RCT 2026, there's a RESET trial. This RESET trial was a multi-center pragmatic RCT published in PMC 2026. 55% of PNS patients achieved at least 50% pain relief at 3 months, compared with 26% only with the usual interventional care. And here there were 222 patients randomized. This is a Department of Defense funded study, and the pain and function gains sustained through 6 months. This is pretty significant. Another long-term RCT, that was Comfort RCT. Here it's a micro IPG PNS was used, and the 24-month outcomes were published. And there's a 84% with significant response, more than 50% relief with PNS and conventional therapy combined, compared to only 3% benefit in the control. So there are several real-world prospective cohorts likewise published durable pain relief and functional gains. And interpreting the strength of evidence, there are significant limitations with peripheral nerve stimulation studies. But the primary limitation was the paucity of there's a very low number of available high-quality literature. That's why we are still at level 3, but this should improve in the future. All effective recommendations rest on level 3 evidence with moderate certainty. So the factors contributing to this main limitations are limited RCT volume. There are few RCTs across a broad range of targets. The targets are huge, but there are limited RCTs. So, and heterogeneous studies, because there are a variety of devices. The protocols are significantly variable, and the follow-up windows are also different. So there's no apple-to-apple comparison. So they're all over. So it's difficult to compare these studies. And the follow-up is also short, and there are also significant scarcity in the long-term durability, revision, and explant data. So this also is also definitely affecting the quality of the evidence. So again, the guidelines are not rigid mandates. They are not standard of care. So, and especially with peripheral nerve stimulation therapy, care is individualized based on the physician judgment and also patient's condition, and also risk stratification, and if they're on anticoagulants and antithrombotics. So the conclusion is clinical takeaways mainly are it's a good non-opioid option, which we need at this time in history. It's a less invasive non-opioid tool, and moderate certainty, that's good for performing this procedure. And there are broader indications in future coming up. That's very good for this therapy, and to be able to offer to all these patients with multiple problems. And individualized care. So this therapy can be applied case by case because we have a variety of devices. So we can choose a device based on the patient's clinical need and condition, and we can target the therapy most appropriately. And also we can risk stratify these patients and provide the best therapy. And also we can plan the therapy based on the anticoagulants they are on, based on the risk status. This will conclude my presentation, and we can discuss the questions at the end. Thank you. I think the next speaker is going to be Dr. Brian Bruel regarding the headaches.
All right.
Hi, Brian.
Hi. Thank you, Dr. Sanapati. Karen, can you tell me if I'm sharing this appropriately?
You can
Not
click on the
sequence.
share and the bottom, and then your presentation will show up.
Is it there?
Yes.
You see it? Okay.
Yep, that's right. You can just click on the slideshow, and your slides will start.
All right. Thank you for inviting me. I'm learning a lot as you all spoke. It's always a pleasure to hear all of you speak. I am tasked to talk about peripheral nerve stimulation for craniofacial pain. And this is a very interesting topic, one of my favorite topics. And I think after hearing Dr. Slavin talk about it, the king of this, this is going to be a fun presentation. So I'm going to talk about the more common things that we do in peripheral nerve stimulation for craniofacial pain. First, I'm going to talk about occipital nerve stim, and then trigeminal nerve stim. And I'm briefly going to talk a little bit about third occipital nerve stimulation in that order, just because we have most evidence behind occipital nerve stim, followed by trigeminal and third occipital. This is the agenda, and I'm going to try to fly through some of this because it might be repetitive from the other presentations. So why peripheral nerve stimulation? Again, for craniofacial neuropathic pain, such as occipital neuralgia, trigeminal neuropathic pain, chronic migraines cluster, and cervicogenic headaches, it's frequently refractory to anything that we do, including nerve blocks, botulinum toxin injections, medications, and even psychological therapy. It's refractory. A lot of times I see a lot of these patients that might have undergone microvascular decompression with continued pain, maybe gamma knife procedure with continued pain that is no longer trigeminal neuralgia. It may be secondary to something we call trigeminal neuropathy. So the PNS delivers targeted subthreshold electrical current to the peripheral nerve via percutaneously or surgically placed leads with an implanted pulse generator. The newer devices out have different wearable type of energy creation for the IPGs. The proposed mechanisms, I think Dr. Slavin talked about this, and when we compare it to central neuromodulation, such as spinal cord or deep brain stimulation, it is very much less invasive. In my mind, medically necessary, like Dr. Manchikanti talked about, because not everyone can undergo a deep brain stimulator, especially for craniofacial pain. It is reversible. It is overall safe compared to the other options we have for neuromodulation. Patient selection and trial stimulation, this was already discussed. We need to confirm the target. Again, this is a named peripheral nerve. It is not a peripheral nerve stimulation. You name the supraorbital nerve, supratrochlear nerve, infraorbital nerve, occipital nerve as your target for the craniofacial targets. You want to optimize the whole patient, just like you would for any neuromodulation strategy. Screen for psychiatric comorbidities. Multidisciplinary pain evaluation is recommended, as already discussed. There is a percutaneous trial, typically 5 to 10 days for most of the peripheral nerve stimulators, particularly for the craniofacial nerve stimulators. And again, this is a repeat greater than 50% pain reduction with meaningful functional improvement. If you have a headache patient, were they able to go to work, reduce their pain medications, reduce their migraine abortive treatments, sleep better because they have less headaches or facial pain. There are so many different options for us now to choose for peripheral nerve stimulation, and there is such a thing as surgical paddle leads in the literature. As I was preparing for this, there is some discussion about using a smaller paddle lead that could be available because of reduced migration. Some key evidence from Dr. Sharon's publication showed that potentially putting the IPG pocket closer to the area that you're stimulating seems to show better outcomes, greater surgeon experience with craniofacial stim, also reduced stimulator-related complications. So going to the lab that's coming up soon, that ASIPP sponsoring might be a good idea to get your hands wet if you're new to this. So let's talk in more detail about occipital nerve stimulation. We can talk about some of the anatomy and some of the techniques. I do have to preface prior to talking about this, once you start learning different techniques, there's a lot of different techniques. There's a lot of different ways to do this that a lot of people might teach you. in different capacities. I'm going to go over what I think is most traditional and most common, but there are nuances to implantation and trialing of occipital nerve stimulators. This is the anatomy. Brief review. The greater occipital nerve arises from the dorsal ramus of C2, and the lesser occipital nerve arises from the cervical plexus from C2 to C3, just posterior to the sternocleidomastoid. They both emerge at the superior neutral line in this area. And cadaveric mapping identifies multiple fascial and vascular entrapment points along their course. So a different lecture in identifying some people with the causes of occipital neuralgia could be nerve compression at any of those vascular or fascial planes. And this is a really good technique to control those symptoms. The indications include the classical occipital neuralgia, chronic migraines, medically intractable cluster headaches, and cervicogenic headaches. So the traditional surgical technique that you can see described in multiple papers includes these steps: positioning and landmarks. Typically, the patient is placed in prone position or something called park bench position. And you can see that in the lower right of the screen. This is the park bench position. Landmarks includes the mastoid tip, external occipital protuberance, C1 arch confirmed with fluoroscopy or ultrasound. I typically do this approach via fluoroscopy. This is how I learned it initially. And what you do is you place a 2E needle, introduce it horizontally about 1 centimeter below the neutral line, spanning the greater occipital and lesser occipital nerve. And so you place it in the plane, typically above the muscles, but I'm going to talk about other ways to do it that I've started including in my practice. Typically, it's above the muscles in that subcutaneous plane, and then you can get stimulation of the nerves as they emerge superficially. The trial stimulation confirms paresthesia. Coverage matches the patient's pain distribution before committing to the permanent implant. I do trial stimulation. I have them wake up during the procedure, during the trial, to make sure that I am capturing those nerve branches. In terms of anchoring, the recommendation is to have a 2-point anchoring system with strain relief loops. You can use a narrow paddle electrode. I'm not sure if that's available currently through Abbott, or you can use an anchor-free 45-degree tunneling technique that I saw published in the past. Important to note that the no anchor technique with the 45 degrees, I have played with that in the past because it seems the thought there is because the anchoring site and strain relief seems to be where the areas of erosion take place, that 45-degree angle without the need for an anchor might be a way to reduce the risk for erosion at the anchor site. Site of the IPG, you could tunnel it to the infraclavicular area. Some patients prefer the gluteal or abdominal pocket. It's very important to consider placing the IPG as close to the target nerve where the lead is so that you can minimize mechanical stress. So infraclavicular probably makes sense for craniofacial stimulation. So this is a sort of a illustration of how the classical way to implant this would be. Find C1 on fluoro and just below the neutral line. Here is the greater occipital, third occipital, and lesser occipital. You place that across that neutral line. And then this is a way to put strain relief to minimize or mitigate the risk for migration. So the outcomes and complication. I want to talk about the complication because how are we going to refine our implant technique without knowing what could happen if what has been happening with these implants? So the biggest complication and most talked about is lead migration. We need to figure out how best to anchor the leads down or keep them in place. Sometimes you have persistent pain at the implant site, risk for infection. Of course, if you have an erosion, there is likely risk for infection. I do have to say that if you do have an infection with a peripheral system, it is not in the spinal column. It is something that I'm a little bit more able to probably salvage rather than immediately taking it out. If there is a little bit of a cellulitis there, I can probably salvage this implant. So adverse events occur in about 70% of patients, but rarely serious. Infection, persistent implant pain, and hardware malfunction are the most frequent, and this was published by Sharon and Dodick in 2015. The evidence base, I'm going to skip through this slide because it was already talked about a lot with our other speakers. So why ONS outcomes vary? You see that the outcomes vary in terms of occipital nerve stimulation. And some authors suggest that maybe we should standardize the way we implant it. So the traditional way, there was always concern about lead migration. So various ways to implant have been published. So this is a group that I think it was in Brussels, systematically reviewed PubMed articles, and they found that ONS anatomy, technique, and outcomes for refractory cluster headaches found that pooled response ranged from 35.7 to 90% across studies for cluster headache. That's a huge range. And so the thought is that you can get closer to 90 if you were able to standardize a way to implant where it doesn't migrate, where you don't have complications, and you always hit the target nerve. So the anatomical landmark descriptions are wildly inconsistent. The traditional way we talked about this, and there is no agreed reference point where some of these nerves might live, especially if you're doing it under fluoroscopic guidance and not actually visualizing the nerve under ultrasound. So there are some folks that will teach you a lateral approach, entering with your needle from lateral to medial, and I do this is medial to lateral approach. Some people discuss going in midline at C2. I've started doing that approach because I use ultrasound to identify the occipital nerve as it traverses over the obliquus capitis inferior muscle. However, if you're doing this under X-ray guidance, landmark approach using fluoroscopy might be a better way to do this. Most groups are using the medial to lateral approach, but this has not been validated to be a superior way. The imaging preference includes some people doing fluoroscopy, some people doing ultrasound. I think that if you're starting to learn this, you should probably learn both ways because I think as we refine our techniques and get better with this and reduce migration and get better at targeting the nerve consistently, it might be a combination of both techniques. So the standardized protocol that this group discussed was the foramen magnum approach. If you remember me talking about the traditional way that I was taught was finding C1 on fluoro, this group is saying that instead of finding C1, you would enter a little bit higher at the level of the foramen magnum. And if you enter at the level of the foramen magnum, but just below the occipital protuberance, then you can angle this above the nuchal line. And there's some evidence to show that if you're angling above the nuchal line, you're going to get more of the peripheral branches of both the greater occipital and the lesser occipital nerves. So you could get better capture closer to the target nerves rather than going inferior to the nuchal line, as was suggested before. Another study looked at their outcomes after putting in 92 leads. They looked at the trial leads and they did 41 permanent implants. This was the Antwerp study, and they placed it in bilateral greater occipital nerve stimulation. Overall complication rate by their technique was 17.4%, and revision surgery was only 7.6%. This is improvement. They were looking at lead migration, and in their technique, only 3.3% of these leads migrated. And so that was also a benefit. This study was a single center study. It was a Plaisir study. And so they talked about the anchor-free technique. And you can see this anchor-free technique that they did. It was one lead. And this is, if you could see my mouse, across the C1 area. And this is a 45-degree angle. And they don't put an anchor there. They just put the strain relief and tunneled it down. So their study showed that not anchoring this, which kind of makes sense in some of my patients who are old and frail and maybe their skin health is not great, I might decide to use this technique for those patients so that there's less risk for erosion. So when you compare all published ONS implantation techniques, at least that I found, here is a chart that I came up with to compare all the different options. I share this because we are not sure which is the best option at this point. And as you learn how to do this and master your techniques, these are some of the anchoring techniques and pros and cons for doing each of these different ways. I think these slides will be shared with you too. So where the literature agrees in terms of implantation, they agree that positioning matters. Nearly every technique, prone, park bench, prioritize a flex, stable cervical position, and virtually all use the external occipital protuberance inion as a primary surface landmark, even though exact distances from it may vary. I talked about going up or above the external occipital protuberance versus going below. So that varies, but that is a major landmark. All agree that lead migration is the dominant complication driving revision surgery. So we need to be better at figuring out how to anchor these leads. A strain relief loop at the mobile mid-cervical region is nearly universally recommended, regardless of anchoring strategy. So you need that strain relief loop where it is relatively mobile. What there is disagreement in terms of the literature, the trajectory. Some people will say medial to lateral is the best way to implant the leads. It is most commonly published, but there are still some people that will start from the mastoid to go to midline, and then Kurt studies going at the foramen magnum, starting a little higher, and then going up above the neutral line to get closer to the peripheral branches is something out there as well. A lot of these are being taught. There is no head-to-head trial that exists to tell you which one's better in terms of getting to the target and in terms of which technique reduces the risk of migration. There is a lot of disagreement with regards to the anchoring strategy and imaging modality. On the right here is a picture of what I look for when I use ultrasound as my imaging modality. And this is the greater occipital nerve that is sandwiched between the semispinalis and the obliquus capitis inferior muscle. So this, you could very much see that. So my goal now is to go directly to the nerve, regardless of how it looks on the fluoro. So that's not published, but that's something many of us are now starting to do. So again, learn a lot of different techniques here, but sort of understand the anatomy and the issues with the current strategies for occipital nerve stem. This is a slide on lead and skin erosion. I put this there because it's happened to me, not just once, but a few times, that, you know, if you're doing a stimulator in an area without a lot of fluff, and I'm in Houston, and you expect a lot of fluff and soft tissue. In these areas, there's not much tissue to cover these leads. And the anchors and even the strain relief loop. So this is something there. And so I am starting to introduce the use of the on-cue. It's a needle that you could peel. It is less traumatic for the soft tissues, less trauma, better healing, hopefully less erosion. This is another chart that I came up with that will be shared with you with these slides, looking at the complications and proposed mitigation strategies based on a lot of the literature that I reviewed. And this is the literature on the right-hand side that was reviewed. So let's move on to trigeminal nerve stimulation. This has less published information here. First off, the anatomy, you have the supraorbital, supratrochlear nerves, branch of your first trigeminal branch. It's the forehead and periorbital region all the way to the hairline. Your infraorbital nerve in the mid-face, right below the orbit. You could also do the mandibular branch, the third branch as well. This is often combined with occipital leads for pain spanning both craniofacial and occipital distributions. So indications for this, post-traumatic and post-herpetic trigeminal neuropathic pain, supraorbital or infraorbital neuralgia, refractory SUNCT and SUNA syndromes, and chronic migraines, adjunct to occipital nerve stimulation is what we typically use this for. Percutaneous, it's a percutaneous implant. You tunnel traversely above the brow for supraorbital leads and above the malar eminence for infraorbital leads. This is a very vascular area. So, you know, if you're first starting out, I wouldn't go in multiple times with a 2E needle because you're going to cause quite a bit of trauma. You have to practice sliding the lead in gently with very few passes to help with reducing trauma. And also during the trial, if you're putting in a lead and you're passing it multiple times, the problem with that is they won't be able to tell you if it's working because of post-procedure pain. Trial period confirms paresthesia coverage over the pain distribution. Permanent implant places the IPG remotely in the infraclavicular area, similar with ONS. You can use ultrasound or fluoroscopy or a combination of both that I've started to do in my practice. You could see lots of the vessels, and you could the vessels always travel with the nerves there. So you could gently place these leads over the face. So the evidence and outcomes, I'm not going to go through this since there was already discussion on this, but I am going to talk about one of the studies I was a part of at Baylor College of Medicine. It was one of the Curonics studies that eventually got the Curonics device FDA approved for craniofacial stimulation. It was a multi-center IDE approved RCT across 7 sites, including Baylor when I was there. There were 60 patients that received the permanent Freedom PNS implant at trigeminal or occipital nerve targets, and they had no prior temporary lead required. So in this trial, we placed the leads in right off the bat. All the patients completed the initial 7 days on therapy, and during that 7 days, there was 93% responder rate during the first 7 days. Responders were then randomized after the 7 days to active stimulation and deactivated stimulation. So the patients had the stimulator in, but it was not activated. And this lasted for 3 months with the 2 arms. And then it was followed by the reactivation at 3 months, followed up to 12 months.
Hey, Brian.
Yeah.
I think you exceeded your time quite a bit. Can you just
yeah, I'm going
close
to
it up?
Yeah, so
Thank you.
these are
Appreciate it.
the slides, the outcome from that study. And then this is a surgical technique as described from Hayek in that study, the way that this was put in, and I talked about briefly there. So third occipital nerve, worth knowing, it was briefly brought up. There is a study there that there is a 60-day stimulator that can provide some good relief of cervicogenic headaches. Look through this. This is a comparative summary chart of the 3 targets that we briefly talked about and some clinical pearls here. Again, highlight here is typically it's a multi-nerve placement for craniofacial nerve. Anchor leads meticulously. Consider your imaging that you use and have realistic expectations. And then that is it. And here are my references.
Thank you. Now we have Alan Dennis. And he's definitely going to finish in 10 minutes. Thank you. Alan?
Yeah, Brian, I just need you into your share screen so I can put mine up.
Okay, Alan, we can see your name.
Okay. Promise I will finish in 10 minutes if I can get this to pull up. There we go.
Okay.
Okay. There we go. All right.
Yes.
So
Awesome.
I'm going to try to zoom through upper extremity a little bit. We're going to talk a little bit about evidence, but I'm going to focus more on techniques, some of the nitty gritty on things that we're going to try to do in the lab in a month. A few disclosure, minority owner of our practice. I consult for Abbott on some of their technical development, training the reps, and I'm on the board of directors on a couple of different societies. Neural targets that we have, when you talk about home runs for peripheral nerve stimulation, we have in place to get started: shoulder, cluneal, knee. Those are your home run patients that do great. We're going to talk a little bit more in depth about how to place a peripheral stimulator for chronic shoulder pain and the different nerves involved there. There are a few different techniques for brachial plexus for neuropathies through the arm that we'll go through, whether it's supraclavicular, infraclavicular, axillary. And then one other neural technique on mononeuropathy that I see quite a bit, and that's in patients that have a periscapular pain. They always want trigger point injections. It's really more of a dorsal scapular nerve entrapment, and it responds very well to peripheral stimulation as well. Common indications for upper extremity. Hemiplegic shoulder has some of the best literature evidence for it. Non-operative shoulder pain, whether it is patients with severe osteoarthritis that are not surgical candidates for total shoulder arthroplasty, those who've had total shoulder arthroplasty that still have shoulder pain that we see quite a bit. Brachial plexopathies with chronic neuropathic pain to the arm. Any of us that treat a fair amount of cancer pain will see this with previous Pankos tumors, radiation therapy for breast cancer, or other therapies that we'll see this. CRPS from injuries to the arm, various mononeuropathies through there, whether it's median nerve, radial nerve, ulnar nerve, etc., and post-amputation pain. Looking at some of the evidence we have, just one of the several randomized controlled trials for hemiplegic shoulder. In this study, Wilson et al. Took 25 patients, separated them out. 13 got PNS, other got conservative care. And what we saw was significant improvement in pain and pain interference patterns with PNS patients over those that had usual care for that pain. Limitation of the study, it was a limited time frame, so only followed patients out to about 4 months, but the statistical evidence was pretty evident between the pain reduction here. Other evidence that we have on when we have studies that just broke down only for upper extremity pain. Of course, there are multiple other studies that have already been discussed that have higher number of patients that loop in multiple indications. But of those that look at just upper extremity, Coy et al. Looked at over 26 studies that had almost 1,000 pooled patients. Of these, 22 of the studies reported significant improvement in pain score, and looking at quality measures of life, whether it's quality of life, medication reduction. Over 22 of those studies reported improvement in at least one of those factors as well. And this is meta-analysis looking at 5 studies, 157 patients. Most of them showed almost a 5-point reduction in a VAS pain scale, 30% improvement in a disability scores, reported 9.2 complication rate. Most of these are lead migrations, are infection are the most common. This is slightly higher than what we see in dorsal column literature. National average for infection with dorsal column stimulation is about 3%, about 5% for mechanical heart complication rates. So roughly about 8% with dorsal column, about 9.2% with peripheral stimulation throughout these studies. So focusing on shoulder. Shoulder has 3 primary nerves that do most of the innervation of the shoulder. Of this, 70% is the suprascapular nerve. Runs anterior to posterior across the suprascapular notch, sending branches to majority of the rotator cuff muscles and then over toward the posterior glenoid. Majority of what the suprascapular nerve does is through the posterior and superior aspect of the shoulder, extends some to the lateral, but it'll take care of about 70% of the shoulder and again the rotator cuff, so extending more medially through the scapula. Axillary nerve arises again anterior to posterior, coming out of the quadrilateral triangle between the teres muscles and the humerus and the head of the medial head of the triceps. This nerve will wrap around the humerus and branches up to the superior and lateral aspect of this. Typically accounts for about 20-25% innervation of the shoulder, mostly the lateral anterior lateral aspect of the shoulder. The final nerve is the lateral pectoral nerve that does about 5 to 10%, most of the anterior portion. So I mention these nerves because as you're looking at your patient, you're trying to decide targets for the stimulation pattern that you want to see. Being able to evaluate your patient, seeing exactly where in the shoulder the pain is located, what the originating pathology was that caused their pain, helps you decide what to go after for those patients. In a majority of the patients, is suprascapular is often sufficient. If their pain arises toward the lateral aspect of the nerve, then stimulating the axillary nerve will also provide benefit. Typically, when I have patients that their pain is arising more anterior, say maybe more of a nerve entrapment that occurred or nerve injury from an anterior approach shoulder surgery. These I'm going to more likely go after a proximal brachial plexus as being easier to do than going underneath the pectoral muscle to get to the lateral pectoral nerve identification wise. So there are 2 different techniques we can look at for a suprascapular and axillary nerve approach. For these, your patient will be placed in the prone position. That's the easiest way to do these when you're particularly using the Curonics system, that you're just implanting the lead itself. If you're needing to implant a IPG or a micro IPG, say with NALU, I typically have these patients in a lateral position so that I can place the IPG in a infraclavicular place similar to a pacemaker. So when you have the patient in the prone position, the first thing I do is I set the lead across the scapula, placing the distal aspect of the lead near the glenoid to where its target's going to be, and measure out where your IPG is, and I make a line using a marking pin. That tells me basically the medial aspect of where my entry point needs to be. From there, I'm going to turn into a contralateral oblique view with the fluoro, so you get the Y view that you see on the left of the screen. And I'm going to anesthetize the skin and advance my introducer needle, whether it's a 13 gauge or it's a Coude needle to advance the lead, or their introducer probe. And I'm going to advance it right down the belly of that Y, advancing toward the glenoid. When I'm confident that it's advancing that trajectory, I'm going to flip back to a perpendicular AP view and advance the tip of that introducer all the way to almost to the glenoid. And then through that, you can advance the lead through there. Typically, this is starting fairly near the angle of the scapula. This allows us that if you want to place an anchoring suture, you can just about put it to the fascia or even the periosteum of the angle of the scapula to anchor the lead there. From there, for implantation, I then tunnel down the periscapular region and place the lead through there so that the transduction coupling package is clipped to the back collar of the shirt and kind of hang over that region and activate the system for the patient. So for the axillary nerve, you're going to start off the inferior border angle of the scapula and angle the lead up toward the inferior aspect of the glenoid. That's going to place the distal aspect of the lead very near the quadrilateral triangle and capture the axillary nerve quite efficiently. I typically advance the introducer probe in an AP view here, and then turn back to the Y view to make sure that it's maintaining a plane across the posterior border of the scapula in the plane where the axillary nerve pierces the quadrilateral triangle. From the entry point, again, you can anchor the lead to the fascia or even the periosteum of the inferior border of the scapula here, and then tunnel the activating portion of the lead back up into the periscapular region so that it overlies with where your scapular lead is is lying. Ultrasound technique. You're placing the probe right across the groove of the scapula so that you get the view that's on the left. So you'll see the spine of the scapula going into the suprascapular notch, and the introducer probe and sheath that comes with the chorionic system lights up beautifully under ultrasound, and you can see it advance right where you need to. Once you advance the lead through and pull the sheath back, you can double verify, and you can actually see the notches of the contacts of the lead, seeing them across the notch of the scapula. For the axillary, you're placing the probe against the posterior axillary of the humerus and advancing it cephalad toward the head of the humerus, looking for the deltoid and the teres minor, and then you'll see the artery and the posterior supracortical artery and the axillary nerve across that runs just posterior to the humerus. And this would be your target to advance your introducer across there. Supraclavicular plexus is a very nice technique to be able to capture for brachial plexopathy. And I have multiple patients that, again, their pain they have across the posterior shoulder. It also extends to the anterior shoulder and into the bicep. I'll do kind of a combined technique to where I almost use the same entry point for my suprascapular lead and then place another lead advancing anterior over the supraclavicular plexus. For this approach, if you have a awake patient, it's easiest if you have them sitting like you see on the bottom right of the screen. To visualize this under ultrasound, the interscalene plexus is the easiest part of the plexus to identify. Once you identify that, you can start walking the probe laterally until you can visualize the artery and the supraclavicular plexus next to it that's in the top right of the screen there. For this, you're going to do a posterior to anterior trajectory, advancing the probe superior to the plexus and the artery. This is going to keep you safe from getting near the pleura or the lung itself, so not risking a pneumothorax. Again, the probe lights up beautifully under ultrasound. You can see, you can follow it coming directly across the plexus and placing the contacts within a centimeter of the plexus itself. Bottom right of the screen is the fluoroscopic confirmation of pretty much how those leads look, with the distal axis lead being near the first rib. So patients that do very well with this, again, the plexopathy, particularly from cancer pain patients. I have a patient that will be implanting in about a week, did wonderful with the trial. She had a osteosarcoma, the proximal humerus, and had to be resected, and has a distal neuropathic pain to the rest of the arm from a plexopathy from damage from that surgery and the corresponding radiation therapy. There are two different techniques that can be utilized for the infraclavicular plexus. The infraclavicular plexus is nice because you can start actually going toward the cord and being more specific for the part of the arm that you're trying to stimulate. The approach that's provided to me from some of the cryonics folks look at doing a lateral to medial approach, where you are starting almost at the juncture of the shoulder to the torso and advancing toward the clavicular-mandibular junction, doing this under ultrasound to place the lead near the inferior plexus. I personally do not do this approach. I don't care for it for a couple of reasons. One, you're advancing a needle toward where important vasculature is. Any of us that have done anesthesia remember placing an clavicular central line. So vascular damage is it can be easy to do here, and it's not easy to compress the vascular that's damaged because of how the clavicle sits. The other reason is this almost puts your lead crossing a joint line and can lead to migration or lead fracture. Third reason I don't care for this one is this actually advancing closer to the supraclavicular plexus. So you're going to lose that specificity that you can get for going after the more distal aspect of the plexus. The way that I was taught by Miles Day by Dr. Raj via Miles Day for infraclavicular plexus is more of a medial lateral approach. And with this, you have the patient laying on their back. Their arm is at a 90-degree angle with the exterior rotated. And you're going to start your entry point essentially a finger breadth lateral to the mandibular-clavicular junction, and you're advancing the lead toward the axilla. So you should be staying parallel to the rib and staying out of the pleura, and allows you to advance the lead toward the actual cords and be specific. Example of patient I used this on, a patient that had a proximal radial fracture, and the open reduction for it was off of a cubital approach that damaged the radial nerve through there. So we wanted to stimulate predominantly the posterior cord. And so I was able to place the lead closer to the posterior cord and only stimulate the radial portion of the plexus for them. Also important to do this under ultrasound. There's an important vasculature near there, and use the dull probe when you do this to hopefully not pierce the artery or the vein through there. Axillary plexus is similar, placing the probe in the axilla, visualizing the artery and the vein, and you can see the ulnar, median, and radial nerve that are near the artery itself, and the muscutaneous nerve underneath the brachioradialis muscle. I typically start in a distal to proximal approach, or advancing the lead toward the axilla, and then doubling the activating portion of the lead back up toward the proximal aspect. So the patient is going to wear their activating coupler across the bicep, similar to how some of us used to attach our AirPod or Walkman when we go jog.
Alan,
Yes.
Alan,
Yes.
we need to go ahead and stop. It's already 7:30. We need
7:30. Okay.
We have another speaker and panel discussion. I don't know about panel discussion, but at least Andrea needs to go ahead and talk.
I would really like to see the dorsal scapular nerve. We've already got a question about it. So if you could just cover that one really quickly.
Absolutely. Dorsal scapular nerve runs underneath the levator scapula and the rhomboid minor. I see this off of two different injury patterns. One, patients falling off an outstretched arm and getting a posterior force to the scapula, or something that pulled the arm very hard, pulling scapula forward. I'm in Austin, so I have lots of water skier people. And when they gun, I've had patients where they gun the engine too fast while they're holding the ski rope and pull their arm forward and cause this injury.
Yeah, if you could just show the placement of the stimulator. So
placement for the stimulator. I started the inferior portion of the scapula under ultrasound, run up the border of the scapula, advancing toward the nerve just under the rhomboid minor. I apologize. I don't have a fluoroscopic picture of this, but it essentially the lead sits just medial to the scapula on fluoroscopy.
Perfect. Okay. I think I'm up last, and I'm going to really blow through some of this. Alan, if you can, are you unshared?
I believe I've unshared for you, so that should be, you should be up and ready.
Okay. Nope. It's still sharing yours, unfortunately, I think. Let's try one more time. Let's see if that will. Okay.
Yep.
All right. So I've got the lower extremity, and I'm going to apologize because I'm really going to have to go through really fast. I don't think we're going to get the discussion, but just to tell you, I am the Chief Medical Officer of Curonics. This is a lecture about wireless stimulation. So there is a significant potential for conflict here. In 1934, Mixter and Barr identified the herniated disc, and since then we've recognized a whole bunch of different sources of low back pain. When you've been looking at conventional PNS, when spinal cord stimulation doesn't help, you've had to tunnel, as everybody's described, to this distal spot, and you've got pain from the battery site that can be quite significant, and maybe more than actually even the infection risk that we see. So if you're doing a wireless stimulation, there's decreased surgical trauma, decreased post-op pain, no pocket pain, no repeat surgeries. It does, however, require an external power system that needs to be recharged, and you're either doing adhesives or a wearable. So if we start with the superior cluneal nerve, one of my favorites, this is an article we wrote in 2022. This is the physical exam. The superior cluneal nerve crosses over the top of the iliac crest. Usually 5 branches, at least 3 of which go through fibroosseous tunnels. And the nerves originate from T12 and L1, but they get contributions from L2 to L5. And it's the L3, L4, and L5 that are the most medial, going through the fibroosseous tunnels, and those are the ones that get entrapped. These are sensory nerves. These will be patients that have low back pain due to a superior cluneal neuralgia based on physical exam and the symptoms. And it can be either surgical, post-surgical, or non-surgical. These are also SES patients who have had who have an under or unrecognized superior cluneal neuralgia and inadequate back coverage. So this is where you would find the nerves with fluoroscopy. I use a little nerve stimulator. This is a traction spur from a iliolumbar ligament. You can see the nerve under ultrasound as it crosses over. You can actually spot the little fibroosseous tunnels. And the stimulator is placed across the top, on the prone patient, across the top of the iliac crest, and stimulates that directly. And you can use, in somebody who's thin, you can feel the iliac crest. Somebody who's heavier, you may want to do a contralateral oblique to make sure that you're not moving anteriorly or posteriorly. Middle cluneal nerve is that Fortin finger, and we know that that's associated with the sacroiliac joint, but it never made sense when the SI is underneath the edge of that iliac crest and that you can't really feel the SI joint itself. Well, Aota, an orthopedic spine surgeon from Japan, started looking at the middle cluneal nerve. And if you look at your dye pattern, you'll see the medial extravasation going to this structure right here, which is the posterior superior iliac spine, coming from S2, and in this patient, a little contribution from S1, but nothing from L5, nothing from S3. The diagnostic injection is done along the the lateral border of S2. And these are patients who have persistent SI pain after SI fusion or lumbar fusions. And we recognize that this is, again, a sensory nerve. So you'll often find these patients, as we know, people who have fusions will end up with SI pathologies. These patients have had multiple SI joint injections without relief. And the medial cluneal stimulation is placed lateral to the foramen and medial to the sacroiliac joint. And this is actually one of my favorite pictures. This shows the spinal cord this shows the fusion, the spinal cord stimulator that failed, the SI fusion that failed, and the stimulation that gave relief from the medial cluneal nerves. And when we talk about knee pain, we know there are multiple nerves that go to the knee, and that we've been treating it with radio frequency, looking at the superior, medial, and lateral femoral flares and the medial tibial flare. Unfortunately, this just got published July of this year, looking at systematic review and meta-analysis of randomized controlled trials of genicular nerve radiofrequency. And their conclusion was that genicular radiofrequency provides short-term relief up to 3 months, but neither functional improvement nor sustained pain relief. And their findings did not support the routine use of genicular radiofrequency for long-term pain relief. And I would argue that the problem is you're targeting the wrong nerve. It's actually the infrapatellar saphenous that provides the primary portion of knee pain, mostly medial, but also lateral. You see it coming under or through or medial to the sartorius muscle. It is a branch of the saphenous nerve and branches off there, comes through the tibial flare, and on your coronal section MRIs, you can see the neurovascular bundle there. It travels it separates from the saphenous nerve at a variety of levels. It is a sensory nerve, and these are patients who have had total knee replacements, tibial nailing, arthroscopies, ACL repairs, and tendon harvesting. The only nerve that's usually targeted from this approach is the IPS. And here you see the lead placed along the medial tibial flare for a patient with lateral osteoarthritis. And so the idea being that this is, with your diagnostic injection proving it, that this is the main innervator and that the superior nerves are rarely needed to be treated. And then if we look at the posterior tibial nerve, this is the medial arch of the medial arch of the foot and the heel, as well as the bottom of the foot, the ball of the foot, and the toes. This posterior tibial nerve comes through the tarsal tunnel. It gives off the medial calcaneal nerve, as well as the medial and lateral plantar nerves to innervate the bottom of the foot. These are branches of the sciatic nerve from they branch off at the popliteal area and they come down the medial, innervates the posterior, the medial portion of the lower leg and down under the medial arch. This is both a motor and a sensory nerve, so it's not a good candidate for ablations. These are neuropathic pains of the lower extremity, specific mononeuropathies, CRPS, type 2, posterior post-tarsal tunnel repair, postoperative foot and ankle surgical pain, and when you have foot and ankle trauma. And the best seen under ultrasound in the tarsal tunnel, you need to have your probe perpendicular to the tarsal tunnel in this direction from the medial malleolus to the calcaneus. And then you'll see this characteristic vein, artery vein, or the Mickey Mouse ears over the tibial nerve. But you don't want to place your stimulator in the tarsal tunnel. It's already full. So you trace the nerve back more proximally, and you'll see the tibial nerve. And this is looking at peripheral nerve stimulation with this high-frequency electromagnetic coupling in the tibial nerve for the treatment of chronic neuralgia and neuritis of the foot. It was an observational study of 15 patients to treat peripheral neuropathy, and they had excellent outcomes, and with the conclusion that the posterior tibial nerve can be a safe and effective way of treating peripheral neuropathies of the foot. And so very effective. And here you see the lead placement and for a postoperative fibular and tibial surgery. So, why peripheral nerve stimulation? It's one of the most common musculoskeletal diseases, and pain is the most common musculoskeletal disease, a major source of disability. It can be difficult to treat, and obviously we're trying to avoid opioids, and we really like to avoid surgery as well. And so PNS has been used to treat chronic pain for decades. It's progressed substantially. There have been innovations with new equipment, new imaging, and new recognition of nerves, and a growing body of evidence that further increases the adoption. So as Dr. Manchikanti said at the beginning, this is no longer an experimental treatment. It is a well-recognized, well-supported, well-studied, and extremely effective way of offering pain relief to your patients. So this is the first of the 3 complimentary webinars that we have. Don't forget that you've got one on regenerative medicine on August 4th, same time, same station, same bat station, and then the intradiscal therapy on August 6th. And these are in preparation for the interventional technique, actual hands-on cadaver in Memphis on August 29th. It's a unique opportunity to look at peripheral nerve stimulation. If you've been interested, if you'd like to try and get some hands-on, this is a remarkable time to try and do it. And I think I did get through.
Amazing job,
Thank you,
Andrea.
Andrea.
A
I
great
just
job.
want to mention that it is also preceded by a ultrasound workshop. People who are interested in learning ultrasound, it will be a great opportunity. And remember, it is only $200. And we will have the wire disc also. You can join that.
Yeah, the
Apart
Viadisc,
from our,
if you've wanted to try and see what that would be like, that's a unique opportunity to be able to try
it is only about
up and coming
$100.
therapy.
It
Yeah,
is only half a day program, so don't miss on those. So, do we want to answer any questions?
I think Amal had a question about the private pay insurance coverage. I know that Curonics and the other companies, I know for a fact that Curonics has been working very hard, and I understand that the other companies have been working diligently as well to increase the coverage of this. It has been very frustrating because, as you know, with all of these procedures, the insurance companies have simply said that they figured out if they say that it's experimental, they're not required to cover it. And it's been very, very frustrating because we now have, for PNS, we have level 1 studies. The craniofacial study was a level 1 study. And so We have another one that we just published that was a level 1 study for proximal peripheral nerve stimulation. Both of those studies were published in Pain Physician. So it's extraordinarily frustrating to continue to do this battle day after day after day. We're making tiny inroads. Our hope is that those little inroads will start making a crack in the wall.
ASIPP has been working on this
ASIPP has been working tremendously. They've been hugely helpful, both behind the scenes on Capitol Hill.
At least Humana has agreed to cover with the Congress, with the oversight committee, and there are several other insurers. First, we were working at the Medicare Advantage plans and then going to these. We are also asking United Healthcare to cover this. So they haven't responded yet because they didn't respond to us. So they said it's the same thing, but now we are going through the Congress, so we'll see what they say there. So.
But that takes money, and the ASIPP PAC needs to be supported. So if you would like to be able to do these procedures, you have to support ASIPP.
And by the way, we also just submitted a modifier for independent physicians when they work in the hospital or ASC. Now they are losing about 7 to 11% of their fee. So we had meetings and they asked us to submit a modifier. That's what we asked them to. So we submitted a modifier. We are going to see what they say on that, what happens. So, but just to get to the modifier, it took a lot of work.
Absolutely. And again, it feels, Lex, as though we're right back where we were, because we started out fighting the people who were in the surgery center and the hospitals not paying overhead where the private physicians did. And it seems as though we're back at that same spot again.
Okay, so
I think I have a question for Dr. Slavin, if he's still on there. I see his name. This is about the patient we were discussing before the meeting started. Phantom limb pain in the left upper extremity after above elbow amputation. So, Dr. Slavin, do you have any recommendations how to manage this?
I missed the discussion. I apologize for that. But the above elbow amputation can be challenging. You can stimulate each of 3 large nerves simultaneously. You can try to do something at the brachial plexus level. You can do spinal cord stimulation, but this is a peripheral nerve stimulation discussion. So I think if you can pinpoint the source of the pain, and that could be neuroma or could be just area of improper ingrowth of the nerve into scar tissue, and if you can figure out which of those 3 main nerves is responsible, then stimulating that nerve would make most sense. Alternatively, you can stimulate all 3, the radial, ulnar, and median nerve, keeping in mind that most pain usually, for whatever reason, comes from ulnar nerve involvement. And if you can start from one nerve and then stimulate the others to see if it's still needed, that will be something that I would normally do. The idea of catching the pain in a stump actually is very attractive. It responds quite well. With phantom limb stimulation, not so much, and it has probably to do with more the central reorganization than actual periphery. I know Dr. Manchikanti mentioned that adding phantom limb to the evidence review, and I will be interested to see what's happening there. In my experience, stump pain responds well, phantom limb not so much. But in your patient, I'll be happy to talk to you offline about this. But in general, all of these patients kind of individually decided in terms of what the best target would be. And that's a combination of nerve blocks, temporary stimulation, even sometimes surgical exploration of the nerves, and then stimulation with permanently implanted device is more of like a final long-term solution.
Thank you, Dr. Slavin. That helps. If you are going for brachial plexus, what is the approach you recommend?
Challenging, especially for the arm amputation. The plexus is large. As a surgeon who operates on it, I can tell you that there are many ways to approach that. There are some reports about single electrode kind of growing across the plexus and getting good results. I have not seen that. So the nerves are quite large, and catching them from right direction to stimulate those fibers that are interested or involved is maybe remarkably simple, maybe remarkably challenging. So people have done it transaxillary, going from the arm and catching the course of the plexus, especially the lower trunk, from the axilla. There are some reports of putting electrodes directly through the shoulder with ultrasound, seeing where the plexus is and putting this over the upper trunk. But usually if it's entire plexus to be stimulated, then I would just go with the spinal cord stimulation. So it's
spinal cord stimulation has very poor response and very poor reputation.
Absolutely. And part of it has to do with mobility of the cervical spine, where cutaneous electrodes are notorious for migration, both in craniocaudal direction and lateral direction. And the paddles, there's a lot of literature on using paddles in cervical spine, and some of them work remarkably well, and some create a lot of discomfort for the patient. So it's one of those things that there's a big need. I think that there's it's a kind of more of the call to the companies trying to figure out something that will be specifically tailored for cervical spine applications. But for brachial plexus, it's an amazing target, but it's just a large target to stimulate.
Yes.
I wonder if Dr. Trescot has experience with that, because she wrote a book on this, on all this each nerves, and every now and then I look at this and learn a lot of interesting things for myself. But Andrea, what are your thoughts about?
It's very nice book,
amputation?
very detailed, and the pictures and.
Thank you. That's very kind. I've had a lot of success if I can identify a pattern in the missing limb, little finger, thumb, index finger, going back to the stump and treating that nerve at the stump with cryo. And that I've had good success with. The stimulator has been harder to do, I think, because it's certainly the less of the stump that you have left, the less runway you have to be able to place those electrodes. I had recommended a brachial plexus approach using Matt Wiederholz's approach to come over the clavicle and into the neck. But there he does go over to the arm, and it does cross the arm. So I'm not happy about it going across a joint, but he's had good success with it. So that's the approach that I've seen the most successful with multi-nerve phantom movement. But I always ask, because it's amazing how many times people say, well, it's the foot that hurts. Well, what part of the foot? Well, nobody's ever asked me that. It's the bottom of the foot. Well, then I'm looking then at the posterior tibial. And so that's been a very successful approach over the years, for cryo, at least.
Yes.
Say, I've had several patients that I've been able to activate the arm for the supraclavicular approach fairly well. If you're looking at capturing a specific target, so you mentioned ulnar, or if there's a median component, you can still do a two-lead technique, an infraclavicular approach, and placing a lead near the medial and lateral cord and be able to capture that pretty easily.
And interesting enough, I did have a guy with phantom limb pain from an avulsion. It was a German patient, and they were I'm saying, look, you can't do stimulation on an avulsion. But when I talked to him, he had hundreds of shocking pains going down to his hand, even though he'd had a total avulsion, but he clearly had a T1 left. And so I was able to put a stimulator on the ulnar nerve in the upper arm. He'd had it turns out a reconstruction of the elbow as part of that trauma. And he went from having hundreds of shocks a night to having two. and that were managed with, and then we just upped his anticonvulsant a little bit, and all the pain was gone. So it's a matter of really talking to the patient about exactly where they're hurting to see if you can target.
We have a few more questions here about post-Ramsay-Hunt syndrome, neuralgia. So, so is there any role for PNS?
Facial nerve. We've not studied the facial nerve. We did do, but I mean, it's technically would not be that much more different than doing a maxillary approach to the trigeminal nerve. We have had some trigeminal stimulators in the foramen ovale. The I the I actually have seen some Hunt Ramsay that was not central, it was actually post auricular. So I really try and do a very thorough job of identifying exactly what the target is, and it isn't always the target that I think it is.
Andrea, we have patients referred with headpiece post-herpetic neuralgia in the ophthalmic branch area. Would you recommend a PNS,
Absolutely.
supraorbital? Okay.
Absolutely. And the supraorbital approach is a great approach. Cryo as well, but certainly supraorbital stimulation.
So one of the questions is
It's
PNS
interesting
used in
for
palliative patients. Any thoughts?
yeah, I mean,
Well,
there's quite a bit of literature on that. I think Dr. Gulati had a nice review of the
Emmett did a
use
lovely job. Yeah.
of use of peripheral nerve stimulation and neuromodulation in general for palliative treatment in patients with a variety of oncological conditions, and that was very well received. And I think there's plenty of role in that, especially in patients with long life expectancy when you have specifically nerve-related neuropathic conditions. The neuromodulation works miracle.
You do
But
need to make sure that they have the MRI compatibility, and that's because they've got a large MRI load as part of their monitoring. And I think, Anu, you were worried about the erosion since we're on that supraorbital supratrochlear area. The we do not have, I will say Curonics, even though we have the indication, we don't have the optimum lead the for the supraorbital, for the facial portions of it. We're actually teaching right now an C2 stimulation coming up from C7 in the paraspinal area, coming up to C2, finding it really surprisingly not migrating and not eroding. So
I have been doing a lot of those, Andrea, after the advanced course. That's working tremendously well.
they really are amazing, and they are so straightforward and so atraumatic for the patient. So
Yes. Mhm.
I think that's really going to.
I think that's what I want to recommend to the people today. Like during the discussions, there's a lot of discussion on anchors and migration and strain relief loops. I think all that problem is avoided after you got the timed leads. They're keeping the leads in
Exactly.
place. They're not moving. You just use the
They're not
time
moving. There's
and
no tug on them.
you
And
don't
so,
need a anchor. You don't need a strain group. They're staying pretty good.
yeah, I do put an anchor with we have an anchor with the coil in the Curonic system, the tines on one end and the coil on the other, but no
Yes.
specific separate anchor at all because there's nothing pulling it
So,
out.
Andrea, are we teaching this new technique, occipital, in the course, coming course next month?
And yes,
That's
yes.
great. That's great. So please do come and watch that. That's really useful. So I found it very useful.
Yeah.
And the trial success is great with that approach for occipital
Yep.
neurology.
Got one set up in the morning.
The next question is, with the cost of Sprint system seems only available at hospital site of service, any ideas why? And will this change in the future? Why is a question of profits. Will it change in the future? No.
Now, the primary issue with SPR that we run into is the majority of your reimbursement is off of the IPG implantation. right now. And when you have a system that only a lead is placed, it turns you upside down in a private setting.
Right. But if anything, probably Medtronic will increase the prices on the other things to make up for this.
That's right.
So please comment on patient selection and diabetic
Yeah, I think,
A1C.
yeah, I don't, with the wireless systems, because we're talking about tiny incisions, I don't think the diabetic, I don't think the hemoglobin A1C and the diabetes and the hypertension, and for that matter, in many of the locations, the anticoagulants are nearly the influence that they have been for spinal cord stimulation. So if I've got a patient who's got a superficial radial, for instance, if they're on an anticoagulant and they can't come off of it safely, if they're bleeding, you just put pressure on it and it eventually stops. If they've got diabetes, we're talking about two tiny incisions, and they usually heal very nicely, even in the diabetics.
I
And so,
think she is talking about the insurance requirements. Humana requires that your A1C should be less than 7 or 9, something like that. But each insurance company has a different
and and,
level.
and I would argue that the patient who's got pain has an elevated blood sugar. And what we've seen is when you get their pain under control, their blood sugar and their blood pressure all start to go down. And in fact, our biggest problem is making sure that their insulin is being weaned down as their blood sugars drop. Pain causes increased blood pressure and increased blood sugar levels.
So there is another question about a brachial plexus avulsion injury after
Ugh,
boating accident with
what a
radiating
mess.
pain to the biceps area, non-functional extremity, a suprascapular with axillary combination 2 electrode. Do you think it would be a good option? I think, yeah, that is what the question is. It's
Yeah,
kind of.
yeah. Uh, Unfortunately, the biceps area isn't well treated with the suprascapular. I mean, you do get some, but not a ton. Um, I think you have to do the diagnostic injections first. And I would do a suprascapular, see whether it made the pain go away. I'd then do the axillary, see if it made the pain go away. And then I'd look at, but I think the brachial plexus is going to give you a better coverage if you get the right portion of the brachial plexus.
Agreed.
Um,
And I'd also say you'd want to
Alan?
look at your EMG neuro conduction studies to see the degree of injury to that nerve too, and see if you just need to be proximal to it.
Yeah, because distal isn't going to do you any good if the pathology is proximal to where you're stimulating.
Yeah.
And I think that that's a key part. That's with plexus avulsion, all the peripheral interventions, they're destined to fail. People try spinal cord stimulation. Sometimes it works, and I encourage people to try less invasive interventions, but realistically for plexus avulsions, I think neurosurgical, DRES procedure is probably the only one that has been shown to work in large group of patients. But it's quite invasive and rarely done. So I see those patients every now and then. And I myself encourage them to try neuromodulation, but it really hasn't worked that well. So if you feel like suprascapular nerve has some connections, because it may be not participation in avulsion, the avulsion sometimes can be selectively affecting certain nerves, then it's definitely worth trying. But be aware that it may just not cover the area of perceived pain.
I agree, but it's on the scale of things, its risk is relatively low and therefore something that ought to be looked at, considered at least earlier.
Absolutely, absolutely. I encourage people to try everything less invasive than cutting the spinal cord, but unfortunately, it's what we end up doing for actual avulsion, not plexus injury, but plexus avulsion.
Yeah, even IDS with our any fecal therapy with bupivacaine.
It's hit or miss. Sometimes it
Hit or
works
miss.
remarkably well, and sometimes it has no effect at all. People just don't feel it. It just keeps bothering them. There's hyperactivity in the dorsal horn when it's deafferented, and it just continues. So something about our intrathecal medications just doesn't reach that far in the dorsal horn.
Okay, thank you all. That was all wonderful discussion, especially Konstantin. So it is always good to have a surgeon to keep us in line with.
I've got a very quick question for two of the masters of there. I've got a patient with burning mouth syndrome. Glossopharyngeal blocks did great but short-lived. What are your thoughts on neuromodulation there?
Not neuromodulation cryo.
Okay.
You can cryo the glossopharyngeal either at the tonsils, or I've done it and in my book, there's actually a picture of it at the styloid with a combined fluoro ultrasound technique. Glossopharyngeal, there's just too much movement in the neck to be able to reliably get a stimulator there, I think. Brian, do you
Absolutely,
have any?
100%. And it seems to work. I mean, what Dr. Trescot is describing in terms of glossopharyngeal involvement, it's really good for pain in the tonsillar area or like in the back of the tongue. If the burning mouth is around the lips and tongue, I haven't found
Anything.
really
Yeah,
anything that works.
Yeah,
My
this
only
is
hope
all
is
posterior pharynx, but yeah, it's still,
right.
I know it's challenging.
My
posterior
only hope
pharynx, you might have a chance. Yeah.
is a
Okay,
high
guys,
cervical.
let us close. It's already 8:05. We are 35 minutes late. And again, everybody can register for the meeting and come to the workshop, also the ultrasound meeting. And thank you. We'll see you next week on the other webinars. Thank you all. Good night.
Thank you for arranging
everybody.
that.
Good night.